the central extensor tendon, which is the extrinsic tendon from the muscle in the dorsal forearm, which passes over the PIP joint and inserts on the middle phalanx. So let's look at this a little bit, a little more closely. Okay, so here's our extrinsic extensor tendon outlined in red here. It comes from the, let's say, the extensor digitorum communis in the dorsal forearm, goes underneath the extensor retinaculum, over the back of the hand, over the PIP joint, and inserts on the middle phalanx. And its function is to extend both the MCP and the PIP joints. And that is innervated, of course, by the radial nerve. The lateral bands outlined here in blue are the tendons of the lumbrical muscles. Now, if you will recall from our anatomy lessons and our discussion of flexor tendon injuries, the lumbrical muscles originate from the on the volar hand, from the fibroosseous tunnel and tendon, and that's why if you cut a flexor tendon volarly and it retracts, it usually will be stuck in the middle of the palm, and the reason for that is that it's held up there by the lumbrical muscle unless it tears away. So the lumbrical muscles are located on the volar hand, but the tendons of the lumbrical muscles then come up into the finger and pass on the radial and ulnar sides of the finger, and then fuse over the DIP joint to form the terminal extensor tendon. So the terminal extensor tendon is really a fusion of the two lumbrical tendons, and it inserts on the distal phalanx. And so the lateral bands do two things. It flexes the MCP joint, if you recall, the position of function is to have the MCP joints flexed, and it extends the DIP joint. So that's the lateral bands. Together, the lateral bands and the central extensor tendon, the triangular ligament, and the extensor hood here form the extensor mechanism. And here you can see in a cadaver dissection the terminal extensor tendon. Remember, that's the fusion of the two lateral bands here on either side. And you can see the triangular ligament, which is this basically soft tissue bridge connecting the two lateral bands. Okay. Now, for distal injuries, that is injuries of the extensor tendons in zone 1 to 4. Remember, zone 1 is over the DIP joint, zone 2 is over the middle phalanx, zone 3 is over the PIP joint, and zone 4 is over the proximal phalanx. Any extensor tendon injury in that region, you can repair that with monofilament nylon, usually 4-0, with a P3 needle. You try to get a small sharp needle, and if you don't have them, see if you can get your hospital to order some for you. And then, so that can be done with just figure-of-8 sutures or mattress sutures or whatever it takes to get the tendon together. But as you go more proximally in zones 5 to 8, you can use the modified Kessler suture, which we learned about in 2 weeks ago. So here you go, you go inside the tendon, come out, then come transversely across the tendon, bring it around and then go outside in on the tendon. Same thing on this side, inside out, transversely, outside in, and then you cinch it up and tie it so that the knot is inside the Neurrorhaphy. And the reason that that's important is that will minimize the interference with the tendon gliding back and forth. Remember, well, we not only want to get the tendon together, but we want the tendon to function so we can actually move the fingers and it glides. So let's just go over the zones one more time. The terminal extensor tendon inserts over the distal phalanx at zone 1. Zone 2 is over the middle phalanx. Zone 3 is over the proximal, the PIP joint, the proximal interphalangeal joint. Zone 4 is over the proximal phalanx. Zone 5 is over the MCP joints. Zone 6 is over the back of the hand. Zone 7 is the extensor retinaculum. Zone 8, dorsal forearm. Okay. So let's talk about zone 1 injuries. If you have a zone 1 injury, you lose active extension of the distal interphalangeal joint, and that's called a mallet finger. You guys don't play much baseball in Africa, but in the United States, where baseball is a very popular game, a lot of players have what we call mallet fingers, because the hard ball will hit the end of the finger and rupture the tendon. Sometimes it's associated with a fracture. So the treatment of a mallet finger is to hold the joint, the DIP joint, in extension for 6 to 8 weeks. Now, it's very important that you maintain motion of the PIP joint when you do this. So this is a mallet splint. Sometimes they have commercially available mallet splints. The best mallet splint is one that's placed on the dorsally, and it's you can just take a tongue blade, for example, make it well padded, and then cut it if you don't have one, a commercial splint, and just splint it splint the DIP joint extension, but leave the PIP joint free from motion. And so you get better extension with a dorsal splint, but you pay a price for it because there are more skin complications with dorsal splints than with volar splints. So you'll have to, so you and the patient will have to monitor what's happening with the skin, and you can move a dorsal splint to a volar splint if there's beginning to see skin breakdown. Another option is if this is a sharp injury, you can actually fix the terminal extension tendon, although it is paper thin. It is very difficult to fix it because it's paper thin. But you have another option, and that's to put a K-wire, which we talked about last week, just through the end of the finger across the DIP joint, and that will hold the joint in extension. Now, if you don't have K-wires, there is another option, and I've used this many times, and that is you can take a 20-gauge hypodermic needle and put it on either side of the DIG, go through the end of the finger, hugging the distal phalanx, just come across the DIP joint and go just up to the distal PIP joint so that the PIP joint can move. So you put one hypodermic needle on one side, and then you put another hypodermic needle on the other side, and that often will work almost as well as a transarticular K-wire across the DIP joint. So that is a nice way to hold the DIP joint out in extension until the terminal extensor tendon heals. And as I said, you have to keep it immobile somewhere between 6 and 8 weeks. Any questions about zone 1 injuries? Anybody have any experience with zone 1 injuries that they want to share with us? Okay. So now we're going to go to, yep. Anybody want to make a comment?
Oh,
Okay. So now we're up to zone 2 injuries. Zone 2 injuries are over the middle phalanx. It's not a big deal. Again, it's a simple repair with 4-0 non-absorbable suture, preferably monofilament. And then the aftercare is the same. You want to splint it with the DIP joint in extension, but leave the PIP joint free to move. Okay. Now, this is a very, very important concept. Zone 3 injuries is basically an injury of that central extensor tendon that comes across the PIP joint and inserts in the middle phalanx. Because if that gets cut, as you see here, you can get a boutonniere deformity. Now, I don't know if we have anybody from a francophone country on listening today. Sometimes we do, but they know that boutonniere means a buttonhole. So it's a buttonhole deformity. And the surgeons who were figuring this out in the 19th and early 20th century likened the deformity to a button coming through a buttonhole. But what happens is, if you don't fix this correctly, the PIP joint herniates up through the extensor mechanism. And the lateral bands, which are up here laterally, then are moved down volarly. So you have the PIP joint is up and the lateral bands are pulled volarly, and you get this kind of deformity where the PIP joint is flexed and you get hyperextension of the DIP joint because the lateral bands, which form the terminal extensor tendon inserting on the distal phalanx, are now pulling volarly, hyperextending the DIP joint. And a chronic boutonniere deformity is very, very, very difficult to fix and end up with a functional finger. So you want to avoid this if at all possible. So if you see these early, you want to fix them, and then and then you can splint the PIP joint out in extension, leaving room for the DIP joint to move. And if it's a complex injury and this kind of PIP splint is not going to work, you can put a K-wire across the joint as well, temporarily. So that is the management of zone 3 injuries, and our goal is to avoid a chronic boutonniere deformity, which is herniation of the PIP joint through the extensor mechanism, allowing the two lateral bands, which are, you remember, are the tendons of the lumbricals, to pull volarly, thereby pulling the DIP joint into hyperextension. Okay, so here you can basically see what we've just been talking about. I don't think we need to spend more time on this. Now, zone 4 injuries are over the PIP joints, over the proximal phalanx. And that's a straight, that's not a big deal. You just explore the wound, you'll see the cut, and you can repair it with mattress sutures or figure of 8 sutures or whatever you like. Zone 5 injuries, now we're getting into a much thicker tendon, but this is a very dangerous injury because it often results due to what they call a fight-bite injury. In other words, somebody is having a fist fight, punches the guy in his front teeth, and the teeth actually make a cut like this, going down through the extensor mechanism into the joint capsule, into the joint. So what you have is an injection of anaerobic bacteria from the mouth into a closed space, because as soon as this happens, the patient extends his fingers and that closes the MCP joint. The MCP joint, of course, is white. It's got a lot of cartilage and bone in there. Very poor blood supply. The extensor tendon is white, poor blood supply. And so you have a setup for a terrible infection. And if you see that, this is a big deal. You got to do an extensive irrigation, wash the joint out, remove any foreign bodies, obtain cultures if that's appropriate, leave the wound open, and elevate the hand and treat it with antibiotics. This is a very big deal. And if you don't do it right, you can end up with a hand that looks like that, a severe hand infection. So all human bites are a big deal and need to be treated aggressively to avoid a necrotizing infection like the one you see here. So the tendon repair is easy, but the challenge is to prevent a necrotizing infection if the zone 5 injury is due to a bite. Now, if it's a clean cut from a knife for some reason or other, a work injury or something that occurs in the kitchen, that's a different story. But if it's a bite, it's a very big deal. And here you can see how thick the tendons are here. And here they've done a beautiful neurrorraphy with good approximation. And then one would expect a good functional result from this kind of tendon repair. So in summary, we want to splint the DIP joints and extension for zone 1 injuries. We want to splint the PIP joint and extension for zone 3 injuries, and both in zone 1 and zone 3, one can use transarticular K-wires to hold the joint extension. Remember that little trick for DIP joint extension of using a hypodermic needle, a number 20 needle on either side of the joint. I've done that many times. It works well. You want to repair all tendon injuries and immobilize for 6 to 8 weeks, except for passive range of motion. Now, you know, what we haven't really emphasized in all these talks is the critical importance of the dressing and aftercare, because seeing the patient frequently, and I realize that resources are limited and you might not be able to do this as often as you want, but if the patient can be seen by either by the surgeon or by some healthcare professional like a nurse who can gently put the joints under supervision through a range of motion, what we don't want to end up with is a stiff hand that doesn't move after 4 to 6 weeks of immobilization. So getting a pain-free hand with full range of motion is our goal. Now, for zone 7 extensive injuries, which remember are injuries through the extensor retinaculum, we make an effort to preserve the extensor sheath if at all possible. And the reason for this is that you can get bowstringing of the extensor tendons. What does that mean? When the wrist extends, instead of the extensor tendon being held flush against the carpus, they will balloon out, and you'll get a poorly functioning extension. And you can use that sometimes with zone 7 injuries. The tendons will retract proximally, and you can use that same trick that we used with flexor tendon injuries. Remember when for zone 2 injuries, we passed that infant feeding tube through the fibroosseous tunnel, sutured the end of the retracted tendon to the feeding tube, and then pulled it back through the tunnel. You can do the same thing with extensor tendon injuries by passing an infant feeding tube through the extensor compartment, suturing it to the cut tendon, and then retrieving it, and then doing your. And once you retrieve it, just take a hypodermic needle and put it transversely across the tendon. That'll hold it in place, and then you can do your tendon repair. Okay, so that completes our study of extensor tendon injuries. Does anybody have any questions at this point before we move on? Everybody clear on extensor tendon injuries? Anybody have
Yes,
any?
there's a question about the human bite tendon injury.
Yeah.
Recalling what we learned in the few lectures before, that you need to leave it open and do some debridement. What does it have an impact on delayed on tendon repair when you do delayed tendon repair? Are there any considerations that you need to take care of, or are there any problems that are associated with late tendon repair?
That's a fantastic question, and we'll talk about it with human bite, but it actually is a good question about all of these injuries. The most important thing that we have to have is we have to have good soft tissue coverage that without infection. That's goal number one. If we can achieve good soft tissue coverage without infection, then we have something to work with. If we could do a beautiful tendon repair, but if we then get a terrible infection, the tendon repair is going to break down, the tendon is going to necrose from the infection, and so you'll have shortening, and you'll have a tremendous scar there, which means that the tendon, even if you put a tendon graft in there or do something, the chances of it gliding are very small. So our first goal in managing hand injuries is to get good soft tissue coverage without infection. And so let's say you have a human bite to the hand with an extensor tendon injury. Personally, what I would do, I would wash the thing out, leave the wound open, maybe take them back again and wash it out again, if depending on what the situation is, you have to use your judgment. Then you can consider delayed primary closure of the skin. In other words, if there's no infection, everything looks good, you can put a couple of stitches in and close the skin, and then go back a week or two later, and then repair the tendon. And for zone 5 injuries, you're not going to get a lot of proximal retraction. So tendon ends are going to stay pretty much where they are. So you won't have this issue of the tendon being retracted, the muscle retracting, and then you can't retrieve it like you do with flexor tendon injuries. So zone 5 injuries, pretty much they stay there. And then, of course, you can use your judgment. If everything looks perfect and you want to repair the tendon on the second trip back or the third trip back, and everything looks great, that's perfectly acceptable too. You have to use your surgical judgment. Did I answer that question sufficiently, or do you have any comments you want to make, or any further follow-up question? Okay, sounds like not. Any other questions regarding extensor tendon injuries? I just mentioned, if we look at this, I just mentioned one other thing that sometimes you'll get a spontaneous rupture of the extensor pollicis longus tendon. And it's called a trommel finger. And trommel is like a German word for drummer. And in the 18th and 19th centuries, they used to have these drummer boys in the army, and they would beat drums with their thumb. And so what would happen is the extensor pollicis longus, because they were beating the drum, thousands of times, would move back and forth. And there is a nodule on the end of the radius, which is called Lister's tubercle. and it acts like a pulley, because the extensor pollicis longus muscle is a straight muscle coming up and down the forearm, and yet, as you can see here, the extensor pollicis tendon makes a turn to go over the thumb. So this tendon with Trumbull finger is rubbing back and moving back and forth over this bone, and in some cases you would it would erode the tendon, and the tendon then would rupture. So that's called a Trumbull finger, and you can almost never do a primary repair of this. The treatment is to take the extensor indicis proprius tendon. You can, I don't know if you can see it here, but there are two tendons going to the thumb, and the extensor indicis proprius is always ulnar to the extensor digitorum commus. So that's an independent extensor tendon. You can sacrifice that, move that over, and then do a tenorrhaphy between the extensor indicis proprius and the distal end of the extensor pollicis longus. That's called a Trumbull finger. I thought I would just mention that, although it's pretty unusual, and you'll probably spend your career without seeing one of those. All right, well, let's move on to the next subject. Whoops, I screwed up here. I messed up, guys. I'm trying to figure out what's happening here. All right, screen new share. Here we go. All right, can everybody see this slide on nerve injury and repair? Can you guys see the slide? Mugisha?
Yes, it's visible.
Okay, good. Okay. All right. So now we're going to, now we've finished talking about tendon repairs, flexor tendon repairs and extensor tendon repairs. Now we're going to talk about nerve injury. And we talk about nerve repair, everybody starts thinking, oh my God, you have to be a specialist hand surgeon, you have to be a neurosurgeon, all this sort of stuff. Well, it's true that if you're a specialist and you're taking care of these things, that's better. But most of these nerve repairs can be done by general surgeons if they know the anatomy of the hand and if they know the anatomy of peripheral nerves, which we're going to discuss now, and they know certain techniques. Okay? So let's say you've got a median or an ulnar nerve injury from a knife wound or whatever it is, and you have access to a plastic surgeon or a hand surgeon or a neurosurgeon, somebody who is trained to take care of peripheral nerve injuries. Well, the best thing to do there is to wash it out, close the skin, put on antibiotics, elevate the hand, and now we're trying to achieve goal one, which is a good soft tissue coverage and an unaffected wound. Then you can, your expert peripheral nerve surgeon can re-explore the patient and fix it. Okay, but let's say you're in a district hospital and you don't have a plastic surgeon or a hand surgeon or a neurosurgeon that does this kind of work. You can still get an excellent result if you fix the thing yourself. Whereas if you give up and say, "Oh, I can't do this," then the patient's going to have a very, very poor outcome. So let's learn how to do this. So what we're going to talk about in this lecture is the anatomy of the peripheral nerve, nerve healing, that is nerve degeneration and regeneration, Wallerian degeneration. We're going to talk for various techniques for direct repair. We're going to allude to nerve grafting, although nerve grafting really is beyond the scope of this course. And we'll talk about the factors affecting outcome and rehabilitation after nerve injury. So the goal, after we finish this lecture, you should be able to evaluate a patient with a peripheral nerve injury. Actually, we've talked about that before when we talked about the physical examination of the hand. Okay, if you could actually put your, everybody could put themselves on mute, that would be helpful. If you want to be able to establish an accurate diagnosis, make a diagnosis of a nerve injury, and you want to be able to formulate a treatment plan and execute the treatment plan based on your knowledge of nerve anatomy and physiology. Okay, so let's look at this cartoon. This is what a peripheral nerve looks like. And around the peripheral nerve is something called the epineurium. It's basically a sheath, a connective tissue sheath. Within the epineurium, there are multiple fascicles. Whoops, what happened to you? And a fascicle is surrounded by perineurium. Same thing, a connective tissue sheath. And within that, within those fascicles are the neurons and the axons, which are surrounded by endoneurium. Okay, so we have now just think of a coaxial cable or a telephone cable, right? You've got that black rubber around it. Okay, the black rubber around the whole cable is analogous to the perineurium. Sorry, not perineurium, epineurium, the outside. Then within that cable, there are subcables containing lots of different wires. That's the fascicle, which is surrounded by perineurium. And then around each of those little wires within the is another insulation that's analogous to the endoneurium. Okay. So what we're going to learn today is how to repair a peripheral nerve by approximating the epineurium. We're going to discuss other techniques where the fascicles are actually repaired and sometimes even the axons. However, for our purposes as general surgeons, we can get a very, very good result by doing an epineurial repair. Okay. Now let's talk a little bit more of the peripheral nerve structure. The axons are the single nerve fibers. That's these little things within the perineurium, and it's like the wiring inside a cable. The epineurium surrounds the nerve, as we talked about, and when groups of fascicles surrounded by groups of axons surrounded by perineurium are called fascicles. Now remember, if you look at the bottom of this particular cartoon, this is the motor axon, and the cell body is located in the spinal column, in the anterior horn of the spinal cord. The sensory nerve goes out to sensory receptors here. The nerve body is located in the dorsal root ganglion, and then it connects to cells within the dorsal and the dorsal portion of the spinal cord. And there are various types of sensors in the soft tissue, Meissner's corpuscles, various nerve fiber endings, Ruffini's corpuscles. But actually, if you if you've ever seen somebody get a cut on the tip of the finger where there are many sensory receptors there, you can actually see with the visible eye Pacinian corpuscles, which are also sensory receptors. Now, the severity of nerve injury and the potential for recovery depends on the mechanism of injury and how severe the injury was. So, for example, if you have a crush injury or sometimes traction injuries, that can damage the myelinating Schwann cells, but the axons are intact. So you might have something called a neuropraxia. Okay, so guys, if you could put yourself on mute, that would be helpful. Thank you. Okay, well, somebody's not on mute, so if you could, everybody could mute yourself, that would be helpful. Maybe you can put everybody on mute. Okay. So Mugisha, are you there? Can you guys hear me, by the way?
Yes, sir. I can hear you.
We can hear you.
So Mugisha, if you could put everybody on mute, that would be helpful.
Yeah, someone. Yeah.
Okay, great. All right, so we're talking about neuropraxia. This is a temporary malfunction of the nerve due to an injury, but fundamentally the axons are intact. The Schwann cells, the myelinating Schwann cells may or may not be injured, and that usually will recover completely. However, if the axon is transected, there is a process called Wallerian degeneration which occurs, and you may remember that from medical school. So when the nerve is cut, the distal axon dies, and then the Schwann cells, which are in the sheath, clean up the debris from the dead axon. On the other hand, the proximal axon will grow and sprout, trying to regenerate the nerve. And you can, and there actually are two types of sprouting that can occur. You can get a terminal sprout, which basically goes straight down and tries to regenerate the nerve, but then the sprouts can also be misdirected and not be very useful. So what we're trying to do when we repair a nerve is repair the epineurium so that when the proximal axon is regenerating, we get a terminal sprout going in the correct direction down this sheath of the Schwann cells, where the previous axon has died and then been reabsorbed. That's what we're trying to do. The growth cone is the term that's used to the distal part of the regenerating axon. And this growth cone is amazing because it is sending and receiving biochemical signals with the environment, and it can change its direction even, desperately trying to regenerate and grow down the axon. So let's say you do a nerve repair. The question is, well, let's say you have a nerve repair at the wrist. Somebody's cut their median nerve at the wrist. How long is it going to take for sensation to reach the fingertips? And the answer is that the nerve will grow approximately 1 millimeter a day. 2 millimeters, I think, is being a little optimistic. But, and the way to assess this is let's say I'm a month out from my nerve repair and I want to know if the nerve is regenerating. You're all familiar with Tinel's sign. Remember, Tinel's sign is if you have a carpal tunnel syndrome and you just tap over the palmaris longus, because the median nerve is right underneath there. And if there's carpal tunnels, if there's a pressure on the nerve, you'll get an electric shock going up the median nerve distribution. Well, you can use that same concept where you just keep tapping distally on the finger and move forward. And then if you now have a positive Tinel sign occurring distal to where you know you did your median nerve repair, that is a sign that the nerve is regenerating and healing as you would hope it to do. So that's a good way of testing whether your nerve repair is working. Do you have an advancing Tinel sign? So it would take about 1 millimeter a day from the wrist to the tip of the finger until you start to feel sensation in the finger. But you won't really get regeneration of muscle function. Really, it's not going to be as good as it's going to get for a year to a year and a half, at least. Okay, so there is, and then there's, so all this time, physical therapy is necessary. Keep all the joints mobile and until such time as regeneration occurs. Now, let's talk about the two commonly used classifications of nerve injury. There's the Seaton classification and the Sunderland classification. And I don't want to spend too much time on this, but I think just spending a couple of minutes will be useful. And this classification helps you determine which nerves will recover, which injuries are likely to recover spontaneously, and which requires surgical intervention. Now, of course, if it's a cut injury and the nerve's cut in half, then it's a no-brainer. You have to operate on that and fix it. So Seaton described 3 types of nerve injury. Neuropraxia is what we talked about before, local myelin damage. The axons are preserved, and there's no degeneration of the axons because the axons themselves are not injured. Then you have axonotmesis, which is a word that'll tie your tongue, but basically the axons are disrupted, but the neural tube, the epineurium, is intact. So while Wallerian degeneration occurs, you get necrosis of the distal axon. The proximal axon is regenerating, but you're in pretty good shape. And the reason is that the epineurium, that is the neural tube, is intact. So the axon has a path in which to regenerate. And then you have neurrorhaphy, where you have complete loss of neural continuity. Just think of taking a knife and cutting the nerve in half. So axonotmesis is when the axons are disrupted, but the neural tube is intact. The neural tube is intact. Neurrorhaphy is when you've lost complete integrity of the neural tube. Now, Sunderland extended this analysis by by dividing axonotmesis into 2 other categories. And let's look at that right now.
Sir, may I ask you something?
Yes, go ahead.
How can I tell if we have an axonotmesis or a neurrorhaphy? Like, can we see it visibly, or can we see it visibly, or what kind of test can we do?
Okay, so that's a great question. And basically, if you have an open wound, okay, we need to put everybody who's not speaking, please be on mute. If you have an open wound, then you're going to be dealing with a complete disruption of the nerve. So you're going to look at it. If you have a closed wound and it's a crush injury, then you're not sure. And so the question is whether or not this crush injury needs an operation or not. If you need to explore the patient, you'll be able to see it. If you're going to manage the patient conservatively, for whatever reason, then you're not going to be sure. Does that answer your question?
Sir, can you hear me? Yes. Not exactly, no, because I'm still not sure, like, what kind of tests can we do
Okay, so
to tell if it's an axonotmesis or complete damage to the nerve? That was my question.
There are basically three types of tests that you can do. You can do an MRI to image the nerve. You can do a nerve conduction studies, which will tell you whether you have electrical transmission across the nerve. And you can do an electromyogram to determine whether or not the muscle that's innervated by the nerve has been denervated or not. But you can't really, so if you've got complete denervation, most likely then you've got the nerve has been completely divided. But I don't think there is a one test that can say without exploring the nerve and looking at it that it's completely divided, or whether this is or whether the neural tube is intact and just the axons are injured within the nerve tube. So I don't. The answer to your question is I'm not aware of any one test that can answer your question definitively without looking at it. But not every injury needs to be looked at. So this is a question of judgment. So
I see. Thank you, sir.
Yeah. That's the best. That's probably not a totally satisfactory answer for you, Maxime, but that's the best one I can give you. All right. Now, for neuropraxia, that is the same as the Seaton classification. For axonotmesis, that is, the axons are injured, but the neural tube is intact. That's the same as the Seaton classification. Now, if the axons are transected and the endoneurium is transected, but the perineurium is intact, that's called endoneurial scarring. So what does that mean? Fortunately, I don't have a picture. It means that the cables within the fascicle, remember the fascicle is surrounded by the perineurium, right? If the axons within the perineurium are transected, but the perineurium itself is intact, that's called endoneurial scarring. And that is better than a complete transection, obviously. In other words, not only is the neural tube, the outside, the epineurium intact, but the perineurium surrounding a bunch of fascicles is intact. So that means that the prognosis is better there. If, however, the axons are transected and you have and in addition to that, the perineurium is cut, then you have a neuroma in continuity, is what Sunderland's calling it. So in other words, within the neural sheath, you have this basically a neuroma growing, and then hopefully that the growing fascicles will head down the intact neural sheath. And then if the nerve is completely cut, in other words, the epineurium is completely divided as well, then you've got neurotmesis, and then you're basically the same as the Sedon classification. So Sunderland broke it down a little bit. Basically, what you have to know as a general surgeon, you have to know that many blunt injuries result in neuropraxia or an injury with the nerve itself, the neural tube intact, and that these injuries are likely to resolve spontaneously. And how are you going to know it's going to resolve spontaneously? You're going to follow the patient over time. And if you don't get an advancing Snell sign or return of neurologic function, then you might consider sometime in the future, whether it's 1 month in the future, 2 months in the future, sometime exploring the patient. And then if you have a completely injured nerve, now you will be able to, if it's a crush injury or a gunshot wound, you'll be able to know where good nerve is located, and then put in nerve grafts. But that is sort of beyond the scope of this course. We're not going to learn nerve grafts in this course. So basically, if it's a cut injury, you're going to explore it. If the nerve's cut in half, you're going to repair it. If it's a injury that does not require exploration, you're going to elevate the hand, treat it conservatively, and then if you have a neurologic injury, you're going to decide then whether to explore it relatively early, that is sometime in the first week, or whether to wait, hoping it's neuropraxia, and for it to improve. And then if it doesn't improve, then then you can consider exploring it. Although in that situation, that would be much better done by a specialist because most of us who are general surgeons are not going to have any experience or particular skill in nerve grafting. Although I'm a general surgeon, I did a fellowship in hand surgery, so I have done nerve grafts, but I haven't done a lot of them. And at this point, if I would have access to a specialist, I would refer that patient to somebody who's doing that type of work all the time. Okay, so let's continue. So in terms of evaluation of a peripheral nerve injury, you have to know the anatomy of the nerve, you have to know the pathology and the methods of classification, and you have to know, obviously, the younger the patient is, the better the prognosis is after nerve repair. A sharp injury has a much better prognosis than a blunt or a crushing injury. And obviously, patients with diabetes, renal disease, any illness that impairs healing or may itself be associated with peripheral neuropathy is going to have a worse prognosis. Now, the physical exam is going to have 3 elements. You're going to look at the injury, and you're going to assess not only which nerves, but all structures which could possibly be injured. So if we're looking at an injury on the back of the hand in zone 4, for example, on the radial aspect of the hand, we know that he could have an injury of the extensor pollicis longus, the extensor carpi radialis longus or brevis, and the abductor pollicis longus and extensor pollicis, abductor pollicis longus and the extensor pollicis brevis. But we also know that the sensory branch of the radial nerve runs in that area. So now we're going to explore the wound. We're going to look at all the tendons, and we're also going to look at the nerve and make sure it's okay. And if it's not okay, fix it. Okay. Same thing for, let's say you have a zone 5 flexor tendon injury. If you remember, zone 5 is proximal to the flexor retinaculum in the distal wrist. So we know that there are 10 tendons there. There, the palmaris longus, and then the 9 tendons that run through the carpal tunnel. We also know that there's the median nerve and the ulnar nerve, right? So we are going to explore that wound, and we're going to look at every single tendon and both nerves to make sure that they're okay. And because unless you do that, you're going to miss an injury, and you won't get as good a result. But of course, before exploring it, we're going to try to look at the motor function of all the tendons that could possibly be injured, and look at the sensory and motor function of the nerve. So we know that, for example, from our previous discussions, that the median nerve is essential to opposition. So we're going to ask the patient to oppose the thumb to the 4th finger. If we're talking about the ulnar nerve, we're going to look at interosseous function, and let's look and see how we do that. So this gives you all the nerves. You already know all this from your previous lectures. Remember, the FPL flexes the IP joint of the thumb. So there's the FPL. You're testing both the tendinous function, and that's median nerve innervation. Here, they're testing the profundus function. Again, we're testing both the tendon itself, and if it's a proximal injury, whether or not we may have a median nerve injury up in the forearm. That's a DPL test again. Here, we're holding the brother fingers out in extension. So if you remember, this is the test for the sublimus tendon, and we are testing, that's median nerve. But of course, it would be, if we would have a proximal median nerve injury, because we would be, if it's a nerve injury, because the nerve, the innervation is up here in the volar forearm. Okay, here is testing for median nerve function, also function of the thenar wad muscles. And the ulnar nerve, remember, the ulnar nerve innervates the fundus tendon to the little finger and the flexor carpi ulnaris. But it also innervates 15 of the 20 intrinsic muscles of the hand, and in particular, it innervates the first dorsal interosseous muscle. So a good test for ulnar nerve function is just have the patient, as you see here, put his hand, the ulnar aspect of the hand on a table, and have the patient abduct the finger against resistance, and you should be able to see right next to the second metacarpal bone, a rock hard first dorsal interosseous muscle. That is almost always innervated by the ulnar nerve. Another good test is to have the patient cross their fingers. Those interosseous muscles are completely innervated by the ulnar nerve. Now, although this looks good in the slide, if you have an acute hand injury, the patient may not be able to do these things because of pain. So if you've got a laceration, you're going to do this. You're going to check sensory function and motor function. Another thing to test for ulnar nerve is power pinch, because the first dorsal interosseous muscle is acting in conjunction with the adductor pollicis muscle, and that's how you pinch. The adductor mollisus muscle contracts, and the first dorsal interosseous muscle stabilizes the index finger, and that's that. And so, if the patient had an ulnar nerve injury, he was trying to pinch that, you would just very easily be able to pull that paper out, between the index finger and the thumb, they wouldn't be able to pinch it. And of course, you're going to check sensory function. We all know this from medical school. The median nerve is called the eye of the hand because it innervates the area where we have fine touch, fine motor function. The ulnar nerve innervates the ulnar aspect of the fourth finger and the fifth finger, all up the dorsum of the hand. And then the radial nerve innervates the dorsum of the radial hand and the dorsum of the thumb. Okay. And we can check for 2-point discrimination or light touch. So let's say we're in the emergency room now. We've done all that. Maxim asked about other tests for nerve function, and this is not for the emergency room, but for say a patient in the clinic with an old injury, and you're not sure what's going on. You can order nerve conduction studies or electromyography. However, I suspect in many of the hospitals, the district hospitals where you're working, you may not have access to these tests, and that's okay because most of the time you can make a diagnosis by history and physical examination. So how are we going to treat it? Well, sharp penetrating injuries should be repaired right away. Traction and crush injuries should be evaluated over the 6 to 12 weeks with serial physical examinations, and you can do EMG and nerve conduction studies if you got them. And then you can determine whether or not the patient needs to be explored or not. So what we're interested in as general surgeons is the cuts. Because let's say we've got a patient with a severe cut on the volar or the dorsal hand. Most of the nerve injuries that we're going to be worried about are going to occur on the dorsal part of the hand. And so we'd like to explore those. And then if we find an injury, we'd like to fix them right away. Now, if it's a gunshot wound, on the other hand, we should not fix it right away. Now, why is that? Because in gunshot wounds, you have injury beyond the edge of the nerve, which is cut, blast injury. And when we first look at the injury, let's say a guy comes in and is shot in the upper extremity, and let's say he's got the bullet transected the median nerve. We don't know how much proximally and distally that nerve is injured, how much we need to debride. So what we're going to do is we're going to tag those nerves to make them easy to find with a stitch. Just put it in through the epineurium and leave the ends long. So when you're re-exploring them, you can find the suture easily and then trace it back to where the nerve is. Because sometimes if it's in the middle of scar tissue, it's hard to find. So what is our goal for acute nerve injury repair? The nerve should result in appropriate alignment with healthy fascicles in a well-vascularized tissue bed under minimal tension. So that means if you have to mobilize the nerve and really crank it together under a lot of tension, you're better off not doing that, just achieving soft tissue coverage, tag the nerves, and then go back and either do a nerve graft yourself or send it to somebody else who's more skilled at doing nerve grafts. Okay, but if the nerve is right there, and you can, which most of them are after an acute injury, you can usually very easily do an epineurial repair. I'm not going to discuss that. This is the point where secondary repair, if there's a crush injury or a gunshot wound, you don't want to repair those primarily. So there are 3 types of repair: epineurial repair, fascicular repair, and as a group, and individual fascicular repair. So this is the workhorse nerve repair for general surgeons who have studied hand injuries. And what you're going to do, you're going to take the 2 edges of the nerve and just put a stitch through the epineurium on each side at say 9 o'clock and 3 o'clock, flip it over, do the posterior row, and then the anterior row. Now, generally, the smaller the suture, the better off you are. So I generally repair big nerves like this with 8-0 suture material. Now, you may not have 8-0 suture material wherever you're working, but Sterling Bunnell, who was the father of hand surgery, who was working in the 1930s and 40s, and he wrote the Bible of hand surgery. He repaired these nerves with 6-0 silk. Now, I'm not recommending that you repair these nerves with 6-0 silk, but he got very, very good results, and he documented his results very carefully. He got very good results with 6-0 silk. Now, we would not recommend using silk for nerve repairs nowadays, but you're better off using monofilament nylon. But if you have 6-0 monofilament nylon on a fine needle, you can do epineurial repairs like this and expect a good result. And this is an example of an epineurial repair. You can see how it you can see how it looks after the repair. So here's the epineurium. Here's the epineurium. You clean up the edges. You can clean up the edges by taking a razor blade on a piece of on a tongue blade and just amputate a millimeter or two of the nerve, so you get fresh fascicles if necessary, and then just put your suture through here, suture here, same thing over here, flip it over, then do interrupted sutures on the posterior row, flip it back, and then do the anterior row. And this is what it should look like when you finish. Here's a video. You got the fascicle there. You don't want to get the fascicle. We just want to get the epineurium. Now, if you're repairing digital nerves, sometimes one stitch or at most 2 stitches is all you need, because they're very small. If you're repairing a big nerve like a median or ulnar nerve, then you're going to need more. Yeah. Okay, so you can see here, this is not rocket science. If you know the anatomy, you've identified the injury, and you've got some fine technique, you can do this. And your patients will be grateful to you if they don't have access to a specialist. All right, well, we're going to move on now. Then there are group fascicular repairs by just repairing the fascicles. This is really beyond the scope of our course. Some people argue that you get better results with this by approximating the fascicles. I'm not sure that I haven't reviewed the literature recently to know whether that's true or not. If it's sitting there and obvious and you want to do that, that's fine. Although really this takes finer suture, 8, 9, sometimes 10-0 suture under magnification. And nerve grafting is, I'm not going to discuss that because it's beyond the scope of this course. And then you can mobilize the nerve a bit. Sometimes you can transpose the nerve, particularly the ulnar nerve at the elbow if you need a little more length. Bone shortening or local joint positioning. If you need to do these things, you probably, that patient probably should not have a primary nerve repair, but really go back later to a well-healed wound and consider nerve grafting. So in summary, we reviewed the anatomy of the peripheral nerve. We've reviewed the physiology of Wallerian degeneration and regeneration. We've talked about techniques for direct repair. We've alluded to the fact that some patients with gunshot wounds or crush injuries might require nerve grafting, but we have not discussed exactly how to do that. And we've talked about the factors after rehabilitation, after repair that can affect outcome, age, comorbidities, etc. And we have not really talked about about rehabilitation after nerve injury, but it's very similar to rehabilitation after tendon injuries. So with that, we will stop. And I think there's about 10 minutes left or so for questions. Mugisha, do you want to take over?
Yes, there are some questions. There's a question in the chat box. You can read around it. And while you are reading, is it possible to do tendon repair and nerve repair at the same setting? And what's the outcome, or do you need to do one at a time?
Okay, that's a great question. And we're next week we're going to talk about mangled extremity, where you have multiple components of the extremity injured at the same time. So the order of repair is, the first you want to do is if you have an ischemic hand, you want to reestablish blood flow. And next week we'll talk about that. The next thing you want to do is fix the tendons. And then the last thing you want to do is fix the nerves. And the reason is that the nerves are the most fragile repair. You want to get the other, and I didn't talk about, you want to get reestablished blood flow, achieve skeletal stabilization, fix the nerves, fix the tendons, then fix the nerves, and then get soft tissue coverage. So that's the order. We're going to talk a lot more about that next week. But the answer to your question is yes, you can fix nerves and tendons at the same time. In fact, you should fix nerves and at the same time. Okay. So Mugisha, you asked a question. I might take it back. So means in our resource limited areas means if you suspect nerve injury in a particular premise, you need to open and explore it. If it's a closed wound, not necessarily. If you have a closed wound and you have nerve dysfunction, but there's no other reason to explore the wound. And we're going to talk about compartment syndrome next week too. Particularly if the patient doesn't need to be does not need fascial decompression, there's no reason to go there other than you think you might have a nerve injury, and it's not an open injury. Then you can manage the patient conservatively and see whether you get return of neurologic function, but over a reasonable period of time, over the next couple of days to the next couple of weeks. If nothing's happening, and you feel you are capable of doing nerve grafting, because that's probably what it's going to take, if there is an injury, if there is an extensive injury, then at an appropriate period of time, somewhere between 1 and 3 months, you can take the patient and explore them and see what's happening. On the other hand, the patient would be best served if he had EMGs, electromyogram, nerve conduction studies, perhaps even some imaging, and then being explored by a person who does this kind of work all the time. if the person has access to that kind of person, to that kind of care. If you're the court of last resort and the patient doesn't have access to a specialist, then I think with some study and assistance, you could consider exploring the patient. But I would wait a good 3 months personally, if there was no other reason to explore the patient except for a neurologic issue, unless we're dealing with a fracture, because the fracture could have disrupted the nerve. So I mean, I should just qualify my statement by saying let's say I have a radial nerve injury in an area where I have a humerus fracture, and most of those radial nerve injuries are temporary neuropraxia. But if I'm not seeing any evidence of return of nerve function and there was a fracture there, then there's a possibility that the fracture itself disrupted the nerve. Okay, any other questions? I'm looking for Mugisha. I'm not as skilled as you are looking at the chat boxes.
There's a question about among the 3 methods of nerve repair that I've mentioned, which one is the most recommended one?
Which one for nerve repair?
Yes, okay. Which technique is most recommended among the few you have mentioned?
Well, the answer is, if you look in the literature, it's controversial. But if you are a general surgeon and you're basically going to be dealing with 3 nerve injuries. You're going to be dealing with median and ulnar nerve injuries at the wrist, and you're going to be dealing with digital nerve injuries in the fingers. Okay, and they are, as we talked about 2 weeks ago, they are frequently associated with zone 2 and zone 3 injuries, the digital nerves. That is in the palm of the hand and in the finger. So digital nerves can be repaired very much like you saw in that video, with 1 or 2 stitches in epineurial repair. Median and ulnar nerve injuries at the wrist, my recommendation is that you do an epineurial repair. That is just, think of a telephone cable. Just put sutures in that, in the external insertion around the cable, line it up, and then there's a very good chance that nerve regeneration will occur down the neural tunnel. So my recommendation for those of you who are like me, general surgeons, just do an epineurial repair. I don't think there may be some advantages to do a fascicular repair, particularly in the ulnar nerve, where the sensory and motor fibers may run in different fascicles. So if you can line it up and see which fascicles are which, you put some stitches there in the fascicles, that's fine. But to do that, you really need fine suture, like 8-0, 9-0, 10-0 suture. So if you don't have that, you're only working with 6-0 or 7-0 suture, my recommendation is just do an epineurial repair. Any other questions?
I don't see another question in the chat box, and it's almost time.
Okay, so how many people did we actually have on this?
21.
21. Okay. Well, I want to thank everybody for joining us. I appreciate it. I hope you found this helpful, and we'd like some feedback from you guys. You can let Mugisha know whether you think this course has been helpful to you, and I hope you can take some of these concepts that we've talked about and apply it in your practice to help your patients. So thanks very much, and I hope you all have a wonderful evening.
Yeah, thank you very much, and Yeah, it's true. We'll give you some slides. Don't worry, Cliff, and just keep in touch. Join the group as we have said before, where I share a lot of information, but this is very helpful. Some people are still commenting on the chat box. Thank you, everyone for being part of this, and we welcome you again next week. We'll be having maybe a final lecture on the hand injuries, and we'll see if we can continue with flap techniques, flap lectures, or lectures on flaps for general surgeons. I wish you all the best, and good night and good morning, Bill.
Okay, thank you. Bye-bye.
Bye.
Yeah, thank
you,
you.
sir. Goodbye.
Bye-bye, everybody.